I'm going to introduce Dr. Imran Ahmed. He is an associate professor of neurology at AASM and the program director of the Sleep Medicine Training Fellowship. He has received his MD at SUNY at Stony Brook School of Medicine, and then completed a neurology residency as well on epilepsy and a sleep medicine fellowship at the Albert Einstein College of Medicine, Montefiore Medical Center. He has been practicing sleep medicine for over 10 years at Montefiore Medical Center, and we welcome him today. Dr. Ahmed.
Thank you for the introduction. So I'm going to just give you guys an overview about narcolepsy. Thank you. Thank you. So I'm going to give you guys an overview about narcolepsy. This talk actually started out to be about an hour long, so I made a lot of revisions to it. So I think I got a good medium put together. So let's see how it goes. So what is narcolepsy? It's actually a neurologic sleep disorder. It results in dysregulation of the sleep-wake cycle, as well as REM sleep dysregulation or instability. So if you look at sleep, there's actually several stages of sleep. There's stage 1, light sleep, stage 2, a little deeper, stage 3, which is deep sleep, and REM sleep. REM sleep is where most people dream. 85% of the time people dream during REM sleep, 15% of the time you dream in other stages. So what happens in narcolepsy is that the sleep stage is actually unstable. The REM sleep tends to intrude when you're awake. It intrudes even into other stages of sleep. So there's this REM sleep instability that plays a role in the narcolepsy, and it plays a role in the symptomatology of narcolepsy. And we'll talk a little bit about the dysregulation of the sleep-wake cycle as well later on. Narcolepsy is actually characterized by excessive daytime sleepiness as well as other symptoms, which we'll talk about as well. And it requires, once the symptoms develop, it requires lifetime treatment. And that treatment varies, and my colleague will definitely speak to you about more treatment options later on today. So, the American Academy of Sleep Medicine actually classifies narcolepsy into two types, narcolepsy type 1 and narcolepsy type 2. That's just nomenclature. But narcolepsy type 1 basically is narcolepsy with cataplexy. We'll talk about what cataplexy is. And narcolepsy type 2, which is narcolepsy without cataplexy. There is some differences between the two, but as a general rule, many people with narcolepsy type 2 eventually go on and evolve into narcolepsy type 1, but that's not a rule, it's just an observation. Okay, so what's the overview? We're going to talk about the epidemiology, we're going to talk about pathogenesis, symptoms, how to diagnose narcolepsy, as well as any associated socioeconomic effects. So let's talk first about the epidemiology. So the prevalence actually varies with ethnicity. About 3 million people worldwide are affected. The incidence is 1 in 2,000 people in North America and Western Europe. Now, I mean, depending on the nationality or ethnicity, it actually does vary. So in the Japanese population, in Japan, it's actually a lot more prevalent, 1 in 600. In Israel, it's actually a lot less prominent, 1 in 500,000. So it does seem to have some sort of ethnicity association. But in men and women, it's equally affected, so there's no gender difference between the onset of narcolepsy. Most cases of narcolepsy are sporadic, but there does seem to be some genetic predisposition. So first-degree relatives of patients with narcolepsy actually have a 40 times increased risk of developing narcolepsy compared to the general population. If you take identical twins, if one twin is affected, there's a 25% chance the second twin will be affected as well, the sibling will be affected as well. So there does seem to be some genetic predisposition. All right. So age of onset. This most commonly occurs during the first 2 decades of life. I mean, as you see, the pointer, okay, as you see, the peak is usually between the ages of 10 and 30, but most narcolepsy patients actually develop the symptoms the first 2 decades of life. I mean, it could be as early as 5 years. I think our youngest patient that we have was 2 years old, which, don't get me, that's a whole different ballgame in terms of how to diagnose that. But 5 years is the youngest in this particular study, and it could be as old as 70 years. I mean, this is the onset of symptoms, not the time of diagnosis. The symptoms actually develop at this age. So, a little bit about pathogenesis. So, the majority of patients have destruction of neurons that produce hypocretin 1. Hypocretin is a neurotransmitter that has been shown in animal models to maintain wakefulness, increase arousal, and suppress sleep. A little thing about hypocretin, it actually was discovered by accident. There were 2 groups studying, one was studying appetite, and they actually named this chemical, this neuropeptide, orexin. And so it does that, but the point being that it does also have a role in appetite control. And we'll talk about that in a little bit in a moment, and maybe it has some relevance. In any case, the cause is unknown, but we think is likely autoimmune related neuron loss. So basically what's happening is the nerves that are producing this hypocretin are dying. And for some reason, we're not sure, we think the body is attacking itself, attacking these neurons and causing degeneration of these neurons. There is some evidence for that, but we can talk about that later if we have time. So orexin, or hypocretin, is actually produced in the hypothalamus, the center part of the brain. I'm sorry, I don't know where the pointer is. Oops. Okay. Well, orexin is produced in the hypothalamus, which is primarily the center part of the brain. It actually projects to all different areas of the brain. It actually is responsible for all the wake. It help you stay awake, helps you stabilize the sleep period, and that's why it has all these interactions throughout the brain. All right, so a little bit about symptoms. The 4 most common symptoms are the classic tetrad: excessive daytime sleepiness, cataplexy, sleep paralysis, and sleep-related hallucinations. The sleep-related hallucinations are both hypnopompic and hypnagogic hallucinations. Hypnopompic hallucinations are basically hallucinations that occur when you're waking up from sleep. Hypnagogic hallucinations are hallucinations that occur when you're going to sleep. And in narcolepsy, these are the 4 common symptoms. We're going to talk a little bit in detail about these symptoms later on. But there are other symptoms in narcolepsy as well. Automatic behaviors, disturbed nighttime sleep, blurred or double vision, difficulty concentrating, memory troubles, memory difficulties, headaches. And there are also other sleep disorders that are very common in narcolepsy patients, like sleep apnea, for example, periodic limb movement disorder, and REM sleep behavior disorder. Sleep apnea is basically a breathing difficulty that people have during sleep that's usually caused by obstruction of the airway. Periodic limb movement disorder is just frequent limb movements that occur during the night while you're sleeping that result in arousals and disrupt your nighttime sleep, or contribute to disruption of your nighttime sleep. REM sleep behavior disorder basically is when you're normally sleeping, when you sleep normally and you end up dreaming, your muscles get paralyzed, your muscles don't move, and that's a natural thing to prevent you from acting out your dreams. So in narcolepsy, one common disorder that occurs is this REM sleep behavior disorder, where the muscles actually are no longer paralyzed and actually you act out your dreams. REM sleep behavior disorder is usually one of the, well, I can't say usually one at first, but if a child has REM sleep behavior disorder, you want to really think about narcolepsy as a diagnosis, because it's very common in children presenting with REM sleep behavior disorder, narcolepsy presenting with REM sleep behavior disorder. So a little bit about excessive sleepiness. while it's present in all narcolepsy patients. It's usually the first symptom that appears, and it's always there. It might get better some days and worse others, but it's always there. People tend to fall asleep in situations where many people would typically fall asleep. Boring lectures, after meals. Yeah, I might see some people dozing off, but that's fine. But that's, actually, just a little aside, it's not normal to fall asleep on boring lectures and after meals or anything, but most people are sleep deprived in our society. Most people are sleep deprived. And that's why right after you eat a heavy meal, you tend to feel sleepy and fall asleep. Or, during boring lectures when you're bored, you tend to doze off. But that's not normal. But, narcolepsy patients do fall asleep in these situations. But they also feel sleepy in situations where most people are able to stay awake. For example, when they're talking to people, when they're watching a movie that they like, or even driving. Falling asleep driving is very, is serious. A lot of car accidents, I'm sure a lot of people here are already aware of. Okay. And more about the sleepiness. Naps patients who take naps actually do feel better. That naps don't have to be that long, about 20, 30 minutes. And it actually does refresh them most of the time. Now, there's a common misconception that narcolepsy patients actually tend to sleep more than the average person, but that's not actually true. I mentioned earlier that there's a sleep-wake instability, this dysregulation. So what actually is happening is that if you count up all these low sleep periods that you have, and add them all together, it actually amounts to roughly the same amount of sleep an average person gets. It's just broken up into throughout the 24-hour period. Maybe a little bit more, maybe a little bit less, but it actually adds up to be more or less the same amount of sleep the average person gets. And this is because of this instability that we have between the sleep-wake cycle. And orexin hypocretin, we believe, helps stabilize that waking period and sleep period. So cataplexy. Cataplexy is a sudden, brief loss of muscle strength and tone. It's occasionally the first symptom, but more often actually develops months or years after onset of the sleepiness. It could range anywhere from a brief feeling of weakness in the knees. It could be like your jaw dropping, it could be your eyelids drooping, or your head nodding. You could have something in your hand, and during a period of laughter or anything, some things drop, or just slight knee buckling. But it actually could also result in a complete physical collapse, resulting in a fall. Most people who actually have narcolepsy and have this cataplexy attack, they don't actually fall to the ground as many times they show on television, but they do need to go down on the floor, and they're able to bring themselves down to the floor. They don't just flop down to the floor. Most of the time they recognize that the symptoms happening, and they can bring themselves down to the ground, or catch themselves and bring themselves to the ground. The persons are fully awake during these attacks. These attacks are triggered by strong emotion like laughter, anger, surprise, and they usually last less than 2 minutes. Now, something more specific to narcolepsy with cataplexy is that just simply remembering or anticipating an emotional anxiety producing situation can trigger attack. So, for example, just thinking of running through a joke in your head in anticipation to tell the joke can actually trigger a narcolepsy attack, a cataplexy attack. So it's just the anticipation of a response, an anxiety-producing response, or a laughter response can actually trigger a cataplexy attack. So, sleep paralysis, similar to cataplexy, but there's some differences. Brief loss of muscle strength that occurs when a person is falling asleep or waking up from sleep. The person is somewhat aware of the surroundings, but is unable to move or speak. It can be frightening, but it's not really it's not dangerous. The muscles that are involved with breathing and your heart are not typically affected. But you can imagine you're waking up from sleep, you're paralyzed, you're unable to move. Really frightening. Many times these paralysis episodes are actually associated with hallucinations, and that's even more frightening. Imagine seeing things moving around and you're unable to move to defend yourself or protect yourself or try to check what it is. So it is quite frightening, but it is not dangerous. So more about the hallucinations. Well, we mentioned the hypnopompic hallucinations when you're getting up from sleep. and hypnagogic hallucinations when you're falling to sleep. Basically, what these are vivid dreams that occur when you're drowsy, when a person is drowsy. It can happen in a normal person. We'll talk about the differential in a minute, but some of these symptoms can actually happen in normal people that are sleep deprived. Hallucinations may involve disturbing images or sounds, animals, people, shadows. It could be a sense of falling, like a vestibular symptom or syndrome. It could be tactile, something like you can feel like the bed is moving or you feel something crawling on your legs. These are all hallucinations that can occur. And sometimes it could be mistaken for hallucinations caused by a mental illness. I mean, sometimes there's a lot of people, I do have patients that come in that were misdiagnosed with schizophrenia or had a psychotic break or psychotic episode, and they actually just had these sleep-related hallucinations. So it can be confused, so you just have to be careful before making the diagnosis of psychiatric illnesses. Okay, automatic behaviors. So automatic behaviors are routine tasks that are performed by a person who is not aware of doing the activity. Occasionally a person may actually fall asleep and continue activity but not remember after waking up. Some of these activities like driving, cooking, talking on the phone, they're all, these are automatic behaviors. So a common automatic behavior about driving, it happens to a lot of people who don't even have narcolepsy. If you could remember yourself coming home from a long day at work and you're driving normally, no problem, no accidents, you're driving very safe, but all of a sudden you realize you missed your exit like 2 exits back. I mean, that's the automatic behavior. Your body, it was a normal process, you just were not mentally focused. Okay? And in children, a common automatic behavior would be that maybe they're writing, they're doing their work and they're writing something, and all of a sudden you might actually see, the child doesn't realize it, but you might actually see that the work becomes very sloppy and then becomes neat again. So that sloppiness period is a period where there was an automatic behavior. The patient was probably just doing things remotely. So, disturbed nighttime sleep. This comes back to where I was talking about the instability between sleep and wake. The brains of people with narcolepsy cannot properly control staying awake or staying asleep. So it's not that a narcolepsy patient can sleep anywhere, all throughout the night. They are constantly waking up throughout the night. Therefore, they have, as I said, they often have trouble staying asleep at night, and this makes their daytime sleepiness even worse. If they're not sleeping well at night, they're going to feel even worse during the daytime. So we spoke about the dull vision, the trouble concentrating, the blurred vision, trouble concentrating, memory impairment, headaches, and the increased prevalence of the other disorders. But other symptoms do also include excessive and unusual dreaming. In children, they might start falling behind in school. In adults, social occupational difficulties might occur, and depression is also a very common feature. I just briefly mentioned the dull vision, blurred vision, but basically what that is when you're in REM sleep, anytime you're sleep deprived, your muscles, your eye muscles get weak, you might have some blurry vision. But when you're in REM sleep, you have what we call hippus, where the muscles contract, your eye muscles contract and relax, and that can actually cause some blurred vision as well. So let's move on. So some symptoms in pediatric narcolepsy: excessive sleepiness, napping, irritability. So in children, many children don't really present as sleepiness, but they can. What happens in children, younger children, most of the time, a child by the age of 5 or 6, they don't nap anymore. I mean, napping ends about 5 or 6. So if a child no longer naps and then all of a sudden starts napping again, that's a sign that something is wrong. They're sleepy. But many children actually present not with sleepiness, but more abnormal behaviors. They're irritable, they're cranky, they don't pay attention. So that's how they manifest sleepiness. Now, cataplexy, they don't usually have the typical, muscle, laughter-provoked muscle weakness of the body, of the limbs. Many times in children, the cataplexy is not actually related to emotion. It just happens. And, as far as we know, it just happens. They might present, cataplexy might present with facial grimaces, like the jaw just drops open, Maybe the eyelids are drooping, they have ptosis, what we call ptosis. The head is just rolling side to side or front and back. They have, a common one is that their tongue starts protruding outward. They start, and some people think it's like a tic disorder or something like that, but it's actually a cataplexy attack they're experiencing. Generally speaking, they have a decreased muscle tone and weight gain. Remember I mentioned the hypocretin orexin actually has a role in appetite. So maybe that's the cause for the weight gain, or perhaps it's just that the child is more sedentary because they're tired, and that's why they're being less active, they tend to gain weight. We're not sure. It could be one, it could be both. We're not entirely sure. But weight gain is associated with narcolepsy as well. Both adults and children, but more prominent children. And poor attention, we mentioned, if you're not, the child can manifest their sleepiness as just not paying attention. So, there are other disorders that mimic some of the symptoms of narcolepsy. Sleep deprivation is just a very common, that presents with a lot of features of narcolepsy. And even some of the objective data that we do can be, if you're sleep deprived, can mislead you to making a diagnosis of narcolepsy. The one thing that narcolepsy, what sleep deprivation does not have, that narcolepsy has, is cataplexy. Cataplexy is relatively specific to narcolepsy, so you wouldn't, if you're sleep deprived, you're not going to have cataplexy attacks. But you can have the excessive daytime sleepiness, you can have those hallucinations, you can have the sleep paralysis, you can have automatic behaviors. So sleep deprivation does encompass a lot of symptoms of narcolepsy. You don't get that fragmented nighttime sleep. You actually tend to sleep deeper and longer when you're sleep deprived the following night. Obstructive sleep apnea, it manifests with fragmented nighttime sleep. You can actually have daytime sleepiness, and it's one of the criteria that we actually rule out sleep apnea before we can actually formally diagnose narcolepsy. Depression can manifest with fragmented nighttime sleep, early morning awakenings, or even the atypical versions of depression can manifest with daytime sleepiness. And hypothyroidism and anemia, you can have, basically you can have sleepiness, fatigue during the day, and again, just some mimickers of the symptoms of narcolepsy. Okay, so let's talk about how to diagnose. Well, first of all, you want to rule out those medical conditions, whether it's sleep deprivation, whether it's the hypothyroid or anemia. So you want to have your healthcare professional look into these symptoms. And once that's been controlled, if the healthcare professional thinks that, well, it's not really anything medical, they send you to a sleep doctor, sleep physician, or sleep specialist who does a history and exam. And if the specialist thinks you have narcolepsy, he will do a sleep study, a polysomnogram at a sleep center, followed by a multiple sleep latency test. Polysomnogram is an overnight study at a sleep center. It has to be at a sleep center. Nowadays, you can do sleep studies at your home as well, but it has to be done at a sleep center. The electrodes are placed on your eyes, your head, your face, your chest, as well as your legs. Sometimes, if you're looking for REM sleep behavior disorder, you have extra leads on your arms as well. You have respiratory sensors measuring your breathing. You have oxygen sensors measuring your oxygen level and your heart rate. You have EKG rhythm strips as well. So you have a lot of wires on, and many times you feel something like this, saying, how am I supposed to sleep when I have all these wires and everything on me? Well, most people do end up falling asleep. But yeah, it is, it's understandable. We acknowledge that it might be a little delay in falling asleep, but most people do end up falling asleep during these sleep studies. But then after this nighttime sleep study, you have to do a multiple sleep latency test. It must follow the overnight study to be considered valid. You can't just do a daytime study. You have to do the nighttime study followed by this daytime study. And we use the same electrodes that we use overnight, but we don't use the respiratory sensors. So you have all those wires on your head, your face, your legs. And basically what it is, we schedule about 4 or 5 naps separated by 2 hours throughout the day. And then we ask you, relax, try to fall asleep. Or do what comes naturally, as the key word. Most people actually do fall asleep. I mean, if they have narcolepsy, they fall asleep, and by classification by the diagnostic criteria, they have to fall asleep on average within less than 8 minutes. Most narcolepsy patients actually fall asleep in less than 5 minutes during these naps. And then we actually measure to see what stages of sleep you actually get into. And if you actually get into REM sleep frequently, this is about the REM sleep instability, your REM sleep intruding into your naps. That's consistent with narcolepsy. So if you at least start dreaming or have REM sleep in 2 of these 4 to 5 naps, it is consistent with the diagnosis of narcolepsy. So we record how quickly you fall asleep and what stage of sleep you enter, and so most people with narcolepsy do enter REM sleep. Okay, HLA typing. Basically, HLA is a human leukocyte antigen, is a term used to describe a group of genes in humans that encode a variety of cell surface markers, antigen-presenting molecules, and other proteins involved in immune function. Basically, just to put in terms, it's just a marker, a genetic marker that identifies what kind of immune response you will have, like an immune system marker. The most common marker in narcolepsy patients is what we call the HLA DQB1 star 0602. It's something that pops up a lot. You might see it, but it's not really a useful screening test. You might say, well, wow, great, there's a blood test for this. Well, it's not the greatest test. If you take a normal population, about 60–70% of the people will actually be positive for this marker. So it's not a great test to screen people with narcolepsy. But if the diagnosis is a little ambiguous, maybe the MSLT or the studies that we did were inconclusive, this can help support the diagnosis. So it's not routinely done, but it can help support the diagnosis. Then the hypocretin level. The neurons that are being destroyed are producing this chemical, hypocretin. Why can't we measure the hypocretin level? Well, it's not routinely checked in clinical practice because it actually requires doing a lumbar puncture to get some of the CSF fluid out. So it's not routinely done. It's primarily used as a research tool, but it actually can be used in a setting where the diagnosis of narcolepsy with cataplexy is unclear. So for example, in a patient that actually didn't develop cataplexy yet. Remember I said you start with sleepiness and within months to years you eventually develop cataplexy. So if you do a test CSF analysis for the hypocretin, you might actually find it low. What's important to know is that narcolepsy with cataplexy, these levels are low. But if you have narcolepsy without cataplexy, the levels are actually normal. So we think that the reason why the levels are normal, they're normal from what our standards are, what we consider to be normal. However, if we had measured this hypocretin level in the same person before they actually developed the symptoms, it probably would have been higher than if we measured it, measuring it right when they're symptomatic. But we haven't proved that, but we think. Okay. Associated socioeconomic effects. So in children, delayed psychosocial development, they have low academic achievement. In all patients overall, there's reduced quality of life. There's an increased risk for work-related or motor vehicle accidents. There's reduced work productivity. There's increased work absenteeism. There's increased annual short-term disability costs per employee. They actually did a study where they found that patients with narcolepsy, they added up all the different costs, medical, pharmacy costs, and they found that narcolepsy patients pay on per year actually are paying 2 times or twice as much as the general population. So their healthcare costs are, a lot more. So this is talking about the study that I mentioned. So they took about 9,000 narcolepsy patients and they matched it with some controls based on the age, the demographics, and financial healthcare plans and so forth. And 46,000 controls, comparing them to 9,000 narcolepsy patients, and they found that, as you see, the annual cost with medications, hospital visits, doctor's visits, it's about twice as much. So it is a huge burden, a socioeconomic burden, at least financial burden, on a patient, on society. So what is it saying? Well, the earlier onset and earlier diagnosis we know is associated with better outcomes. So patients that were diagnosed before the age of 30 actually have been reported to have less unemployment and better health perception than those that were diagnosed after the age of 30. So if we start appropriate treatment, I mean, I have medication, but any appropriate treatment, if it's initiated sooner, then it actually is beneficial to the patient because they actually benefit better if treatment is initiated sooner. Diagnosis is identified earlier. The diagnosis is made earlier. So, summary. Narcolepsy is a neurologic sleep disorder that requires lifelong treatment. 4 cardinal symptoms include excessive sleepiness, cataplexy, sleep-related hallucinations, and sleep paralysis. It requires a clinician to recognize the symptoms and order appropriate tests and studies to diagnose. It does have socioeconomic implications, and early diagnosis and treatment can help mitigate some of the socioeconomic burden. So that's all I have. If there's any questions, I'd be happy to answer them if I can.
Thank you so much, Dr.
Of course.
Ahmed. We're going to have about 10 minutes of questions right now, so I'll be kind of roaming the room, so please raise your hands and I'll come to you.
Good morning. My name is Lena. I have narcolepsy, and my question is, I have a 10-year-old daughter that we're thinking she has narcolepsy. I haven't gotten around to do the appointment for the test, but she doesn't present precisely daytime sleepiness. What she says is she feels very tired. So that's my question. If in children necessarily presents daytime sleepiness.
So daytime sleepiness in children, as I mentioned, it doesn't present necessarily as sleepiness. It could present as tiredness. It could present as irritability. It could present as just not paying attention or just poor academic performance. You know, when you were doing well and all of a sudden they're not doing well anymore. So it doesn't have to present with sleepiness. But I mean, definitely if they're presenting in this atypical manner, just tiredness, you want to make sure that it's not anything else before you go the route of narcolepsy. But yes, narcolepsy would probably be in the differential.
Anyone else?
Hi, thanks for your great lecture. My 11-year-old son has narcolepsy without cataplexy, and he meets the criteria on his MSLT with 2 REM intrusions and whatnot, but he doesn't have a lot of the classic symptoms. He does have a lot of allergies, food allergies, eosinophilic esophagitis, growth problems, and I was wondering if you could speak about histamine and narcolepsy, and are there any connections that you're aware of between people with allergies, food allergies, and narcolepsy or narcolepsy mimicker?
Okay. Well, histamine is a wake-promoting neurochemical, right? So that's why many times when you take antihistamines, you feel sleepy. Okay? So orexin actually affects a part of the brain that actually produces histamine. Okay, and again, if your orexin level is low, that stimulation is not there. So histamine is a pathway of being awake. So in terms of having allergies and that, I mean, we know also that people with narcolepsy, because they have the deficiency of orexin and this hypocretin producing neurons, they actually have an increased number of receptors for histamine. But the direct relationship between having allergies and having narcolepsy, I don't, as far as I'm aware, I don't think that's been looked into yet. I'm not sure, but I mean, theoretically, you can try to make the connection, but the clinical studies have not been done, or research has not been done specifically on that. Oh, there it goes. Histamine, the tuberomammillary nucleus. I don't have, that's the far right. That area of the brain is actually making histamine. instability. So the orexin is stabilizing the histamine production. If you don't have that stability, the histamine level is probably fluctuating. Now, there are new agents that are in development that actually stimulate the histamine receptors that can actually help a person stay awake. But again, not going to speak more of the treatment. I'm sure my colleague will speak more about that. I hope I'm...
My question is twofold. Why is it over time that cataplexy would develop? And then the other thing is there any research or treatment that can help, ameliorate the symptoms of that?
Okay. I'm not entirely certain why cataplexy develops early in some patients and later in others. Many people with I imagine is the location of the destruction of neurons and which pathways are actually being affected first that would result in a cataplexy versus the sleepiness. So if you are if the pathway that results in cataplexy is the first that gets involved, then you'll develop the cataplexy first. If the pathway that's responsible for you to stay awake is a pathway that gets involved first, you're going to develop the sleepiness first. Many people with sleepiness within months, 2 years, actually develop cataplexy. Again, it might be where the pathways are affected, which neurons are being destroyed where, and how the orexin is getting through to the different parts of the brain. And that's, as I mentioned, sometimes cataplexy is the first symptom. So sometimes cataplexy develops first. In terms of treatment, there are, I'm sorry, did I answer your question? Yeah, okay. And in terms of treatment, a lot of the general progression of cataplexy is as you get older, the symptoms tend to stabilize. They get a little better and then they stabilize. We don't know if that's because people learn how to avoid certain situations that result in cataplexy, or if it's just a natural process of what happens with cataplexy. We're not sure. So, controlling certain situations that provoke cataplexy is a behavioral thing. My colleague will speak about more treatments. There's a lot of, there's one FDA-approved medication for the treatment of narcolepsy, for the cataplexy symptom, but there are a lot of non-FDA-approved treatment options for cataplexy medication-wise that we have tried.
Hi, I have narcolepsy, and I noticed one of the things you mentioned was memory impairment was
Correct.
a symptom. Is that something that's commonly addressed, or is there any treatments or behavioral changes that you can do to improve the memory? Because that's one thing that specifically I struggle with a lot is memory.
Yeah, specifically it's not addressed unless the person is complaining about it, and then we work it up as a memory complaint, not necessarily related to narcolepsy. How we believe it's associated with narcolepsy is that when a person's sleepy or sleep deprived, the areas of the brain that are responsible for attention are not working as well. So you're not necessarily focused on that, so that connection is not made to long-term memory. So you might actually forget what you were talking about or what you were told at one point or so, because that the attention was not there, so it was never incorporated into long-term memory. So that's what we think is the cause of the memory impairment in narcolepsy, but we would probably address it as any other memory complaint and treat it as any other memory complaint in clinical practice. Of course, trying to optimize your symptoms of narcolepsy by increasing your wakefulness.
I have time for one more question. I would like to just say, just reiterate, if you have any questions that you did not get answered, please write them on the back of the evaluation form, and I will get back to you with the information. We really, really want to answer your questions, but of course we don't have time to get to everybody's questions during this time period. Thank you. You had a question?
I am curious, do you know anything about orexin and taking amino acids? I've been trying to find out, like, through my son's doctor, but he doesn't know if it's something he could take with the medications he's on.
At this point, I can't say that there is anything that we know about amino acids. Yeah.
Okay, thank you so much, Dr.
Thank you for having me.